much in the presentation schedule. Next, Minu Mathen from Chaitanya Trivandrum is going to talk on IOL centration issues, angle kappa and angle alpha.
Good afternoon, ladies and gentlemen. Thank you, Dr. Soni, for this invitation. ഒരു one-lineറിൽ ഫിനിഷ് ചെയ്യാവുന്ന ടോക്കാണിത്. So I was thinking, if there is a IOL centration issue, you will have a problem in premium IOLs. So don't use premium IOLs if you are expecting. ഇത് തീർന്നു. അപ്പോൾ ഇതിനകത്ത് ഇതിൽ കൂടുതൽ എന്താ പറയുക? അങ്ങനെ ചെയ്യാതിരിക്കുക, അത്രേ ഉള്ളൂ. അപ്പോൾ ഇതിനെ എങ്ങനെ വലിച്ചു നീട്ടി ഒരു 7-minute ടോക്ക് ആക്കാമെന്ന് ഞാനിപ്പോൾ കാണിച്ചു തരാം. So ideally, IOLs should align with visual axis. So there are many axes. Visual axis, when you are looking at somebody and the ray which goes from there and hits the fovea is your visual axis. That's a green line. Then there is pupillary axis. Pupillary axis which goes through the center of the pupil. Pupil may not be central for everyone. It may be at different levels, shifted and all those. And then comes the optical axis. Optical axis is perpendicular to cornea and the lens, a perpendicular line. So angle alpha is between the optical and the visual, angle kappa between pupillary and visual axis. So premium IOLs, they are more sensitive than the regular monofocals, and in regular ones, aspheric is more sensitive. And so measure them by using any of these which is available with you. And if it is more than 0.5, if you get it in millimeters and 5 degrees, don't advise premium IOLs, especially multifocal IOLs. Finished. But then we will go on again. Then what will they have? If you advise and will they have this, they can get blurring, they can get glare and halos, distortion, then focusing issue. ചിലപ്പോൾ എനിക്ക് ഭാര്യയെ നോക്കിയാൽ ക്ലിയർ ആയിട്ട് കാണാം, ചിലപ്പോൾ ക്ലിയർ ആയിട്ട് കാണുന്നില്ല, ഇങ്ങനെയൊക്കെ പറഞ്ഞു വരിക. അപ്പോൾ ഇങ്ങനത്തെയൊക്കെ വേഗ് സിംറ്റംസ് ഒക്കെ ചിലപ്പോൾ ഇതുകൊണ്ടായിരിക്കും. So we should check out for all these things, with dry eye, all those things. Contrast reduction and all those stuff. So then again, anatomically there can be some problems, loose zonules, loose so capsular bag not being circular all the time. It's like that. Sometimes if you place a lens into the bag, in some position it will be little decentered, in some position it will be centered. So that kind of things are there. But if you know that preoperatively, avoid those kind of people. And then capsular axis, if you do it very large, I don't suggest. There can be changes in centration. If your axis is not centered, then some part of the IOL will be covered by the rhexis margin, some part will not be. Then there can be decentration. And discontinuous rhexis. There is so many times there may be decentrations if you place it, if the rhexis is not complete. And then in PCR, you will somehow place a lens, but we can't be sure that it will exactly remain there. There can be changes in location. So I would, and then trauma. Later on, rubbing too hard and all those things, and injury and all those things can cause a decentration. All these decentrations will cause these kind of problems. Later on, capsular bag contraction. See, people who are having pseudoexfoliation, who have RP, and all those people who have loose bags, they can all go in for this contracture, and because of the less counter traction from the zonules, and then also they can end up with this. Maybe initial period you will be okay. Later on they will come and tell you that I am not seeing clearly, and then you can blame for something. നല്ലൊരു അമ്മയ്ക്ക് തിരുമ്മി എത്ര പ്രാവശ്യം തിരുമ്മി എന്ന് ചോദിച്ചാൽ അത് ശരിയാണ്, ഞാൻ കുറച്ച് പ്രാവശ്യമൊക്കെ തിരുമ്മി എന്നൊക്കെ പറഞ്ഞു കഴിഞ്ഞാൽ അപ്പോൾ പിന്നെ തിരുമ്മലിലേക്ക് we can attribute that. അങ്ങനെയൊക്കെ ചെയ്യാം. But then still know that these are things which can later create problems. Avoid. So വീഡിയോ കാണിക്കാതെ എങ്ങനെ പ്രസൻറ്റ് ചെയ്യാൻ പറ്റും ഇതിന് എന്ത് വീഡിയോ കാണിക്കാതെ ഞാൻ പറ്റും ഞാൻ ആലോചിച്ചുകൊണ്ടിരിക്കുകയായിരുന്നു. Again, see, look at this. So this is the centration which you should get. So the P1 and P4, you can see P4, P1, P2 together, P4. They should be in the central ring, and if that is so, when patient is looking at the light, then you are well centered. So the second thing is, sometimes even if the patient looks at the center, there will be slight this one, but the lens looks very centered. So this lens is well centered inside the bag. Can anybody place a lens here in the bag without and position lens in a separate way and think that it will remain there? It will not. Bag is bag. Lens is there. And it has gone to the equator and it is sitting there and it will sit there in the bag. That's all. If you nudge it a little bit, കുറച്ച് നേരത്തേക്ക് അത് അങ്ങനെ ഇരിക്കും. കുറച്ച് കഴിയുമ്പോൾ പഴയ പോലെ തിരിച്ചു വരും. അപ്പോൾ നമ്മൾ വിചാരിക്കും നമ്മളിപ്പോൾ സെൻറ്റർ ചെയ്തു അവിടെ ഇരുന്നോളും. അതൊക്കെ തെറ്റായ ധാരണയാണ്. It will come back to its normal position. I don't think it will stay in your nudged position also. So it will go into the bag, sit where it's supposed to be. So pre-op you calculate. If it is more, if you don't want to place, don't place. Otherwise you can tell something to patient and get away with it. So again, very, very, very old lens, multifocal lens. It has got separated from both the haptics and decentered. അപ്പോൾ decenter ആയ what will you do? So we will go to techniques. We have to deal with these patients. See, this kind of scissors sometimes don't work. This is silicone IOL. This is the only lens material in which I had to use this serrated cutter. IOL cutter. All the others, long tipped 1/2 scissors will work. So this is slightly larger in size. It goes through a 2.8, and rather than opening up too much, I can rotate the lens and cut it. Now, advantage is these kind of haptics which are in the bag can be maneuvered in many different angles and taken out very easily. Otherwise, if it's a full lens, if you try to rotate the lens, you will have to, there are limitations in the angles at which you can pull on these haptics. These are in the bag, you don't know how much of fibrosis is there. So very gently try to pull out, and in different, along the axis of the curvature of the haptic. If you can pull like that, it can cause least trauma. But if it is attached to the lens, you can amputate and then later on take it out in regular cases where you want to take out lenses from the bag. Another cause, placing a lens, a single piece lens in the sulcus, and it is flipped one, definitely it is flipped, but that's okay. But it is a small lens, it's a large sulcus and it is decentered. Similarly, this has to be brought out. It is sulcus, it can be taken out very easily and bisect and take out. Again, when you become sharp shooters, you can shoot kind of lenses deep into the vitreous or into the bag or into the sulcus. Sometimes, no, in a not because you're in a damaged injector, that is the reason. So if it goes and sits there for some time and is not centering, there is something wrong. It's not just like that, it is not going and sitting somewhere. So there is a precedent or a dialysis somewhere there, and in such cases, identify what is there, and if it is small, you can always get away. And you can, don't be so very inquisitive to go there and aspirate and pull out vitreous without, there was no vitreous there. I went there so much close to the rent there and pulled out vitreous. So don't be too inquisitive, just retract the iris and see, and then leave it alone. Don't disturb all these places. And another patient, referred, having glare, and many years post-op, but it is decentered, IOL is well in the bag. But see what happens. I constricted the pupil and saw, the pupil is constricting not completely normal. See, one area is peaked there with some fibrosis and all there. So that means there is something wrong with the iris and the pupil is not covering the IOL. It is not, it is decentered for sure, but it's a regular monofocal lens. And see, this is how you see for the centration. If it is a blocked case, just pull the globe and see whether 1 and 4 are overlap, where Purkinje 1 and 4 are overlapping. So if they are overlapping and it is well within 1 or 2 millimeters into the optic, you can leave that lens and do a pupilloplasty. So again, the technique of pupilloplasty, 4th row pupilloplasty. So visco inside, this is a 10-0 proline and 1 bite on the edges of the pupil and comes out 1 loop, and you take 4 throws, catch onto the free end of the this one and pull along. And one knot is enough and it stays. So identify whether you are centered, and the P1, mostly P1, if it is in the center, it will be good enough. So if that is there, I am going to do one more, no time to show, but then make it smaller, and a small cut on the other side can make the pupil much central and the visual axis. So ideally, do all these things if you have a problem, but then try to avoid this problem by not selecting. But many people nowadays don't actually look at this angle kappa and all those. So, but still, decentration, if you see, in the pupillar area, and if you see only half of the central ring, many of them will have this kind of issues, which some people may not tell, but many people may tell, and it's aggravated by the multifocals. Thank you very much.
Thank you, Dr. Minu, for extending that 1 second answer to 7 minutes.
Yeah.
Thank you very much, and only you can do this. And it was fantastic, all the techniques you showed.
Any devices to measure?
Yeah. One question is there any specific device in which you can measure angle alpha or angle kappa?
Pentacam, you can use all these stuff which all of them will give. Most of the IOL calculators will give, and topography also will give you.